Hello, everyone, and welcome to our webinar. My name is Tracy Cook with Sachs Healthcare Communications, and I'd like to show our audience how to send in questions throughout our webinar. Our speaker will try and answer as many as possible at the end of the presentation. Please type your questions directly into the questions box. You can also download today's presentation from the handout section of the GoToWebinar control panel. I'd like to introduce our moderator, Mary Alexander. Mary recently retired as a CEO of INS and INCC. During her tenure, Mary was responsible for providing consistent delivery of the highest quality education and professional services. She was instrumental in sharing infusion education to all corners of the world, from countries in Latin America, Europe, and Asia Pacific. Mary was also the editor-in-chief of INS premier publication, the Journal of Infusion Nursing. She was published in numerous journals and publications and has been revered as an expert in the infusion industry. Welcome, Mary.
Thank you, Tracy, for that kind introduction. The title of today's webinar is Injecting Evidence, the 2024 Infusion Therapy Standards of Practice. Speaking on this very timely topic is my colleague and one of the authors of this document, Lisa Gorski. Lisa has worked for more than 30 years as a clinical nurse specialist for Wheaton Franciscan Home Health and Hospice, now part of Ascension at Home in Milwaukee, Wisconsin. Lisa is the author of several books and more than 70 book chapters in journal articles. Active in the Infusion Nurses Society, Lisa is an INS past president and was the chair of the INS Standards of Practice Committee for the 2011, 2016, and 2021 editions and co-chair for the 2024 edition. Inducted as a fellow into the American Academy of Nursing in 2006, Lisa speaks nationally and internationally on standards development, infusion therapy and vascular access, and home health care. The speaker disclosed no conflicts of interest associated with this presentation. Continuing education for nurses and respiratory therapists. This activity has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. The accreditation statements are listed below. This activity is supported by an education grant from Dale Medical Products, Inc. Now I would like to turn the presentation over to my friend and colleague, Lisa Gorski.
Thanks so much, Mary, and for that nice introduction, and we're going to go ahead and get started. So we're going to begin with a polling question. I often speak to members of the Infusion Nurses Society, and I'm curious how many of you are members versus not being a member. So if you can go ahead and answer this poll, then we'll get started with the content. So we're going to give it about 30 more seconds or so. And I'm actually hoping that a fair number of you are not members of the Infusion Nurses Society and are attending this conference out of interest of the INS standards. Okay, so it looks like I have to move my thing. So 94% of you are not. Wonderful. So I do enjoy speaking to people who are not members and yet are interested in these standards. So the objectives of this presentation today are to summarize the methodology used to develop the standards, and I won't spend a lot of time on that, but just to help you understand, how we put this together, evaluate some new and changed recommendations within the standards, and summarize some specific research findings that support practice recommendations within the standards. Okay, so this is just a little bit of the history, since most of you are not members of INS, but the first edition of the standards was actually published in 1980, and it was very specific to hyperalimentation. In 19 1984, a one-page edition addressing home care, as home cares really began in the home infusion therapy in particular, really began in the 1980s, to some degree the late 70s. And then in 1998 and 2000, when we were called the Infusion Nursing Association, and then my tenure with the standards began in 2006 as a member, and as Mary noted, that I've been the chair since 2011. Okay, I did it a little too fast. So a little bit about the 2024 standards. They were just published in January of this year. And with this particular edition, we did add non-nurse committee members, a pharmacist and an infection preventionist who is a non-nurse. It is a large document. It's about 285 pages, which compared to 224 pages in 2021, more than 2,500 references. And this is just reflective of the growing amount of research relative to infusion therapy. There were 144 peer reviewers of this document, 117 from the United States and 28 international, representing 12 countries. This document is used globally. I'm fortunate that I have had the opportunity to travel to a number of countries and present the standards. And even for those of you who may not be specifically familiar or purchase the standards, they are widely cited in common policy and procedure manuals, for example, Elsevier and Lippincott, which are used by many organizations. So just a quickie review of the methodology that we use. We basically have a librarian who does searches for each of the standards. We identify the search terms. We go ahead and review all of the references that are provided to us by the librarian, and then we even dig a little bit deeper, looking at references within the research studies or citations that are made available to us. And we develop the standards as committee members. We are assigned specific standards that are our responsibility to develop, but we don't do this alone. We do the initial draft, and then our committee does a complete review of each other's work, and then it goes out for a peer review, and then we make final recommendations. So in a nutshell, that basically describes the procedure. It is very laborious. It accounts for a lot of hours on the behalf of each of the committee members. So it is a work of passion and dedication on behalf of the entire committee. So each of the standards has two components. We have standards and we have practice recommendations. And the standards do not have references, and they're just considered expectations of practice applicable to infusion therapy in any setting. Okay, am I okay? In terms of an example and historical perspective, the least invasive vascular access device with the smallest outer diameter and fewest number of lumens is needed to complete the duration and prescribed therapy is selected. This has a lot of historical perspective because this statement has been in the standards for many years, but we have really growing evidence to support this standard. You know, just a good example is the fact that, you know, in my old days as a nurse, we always put in large peripheral catheters. We always thought that was better, but actually smaller catheters are better for better blood flow around that catheter. So the practice recommendations to support these standards provide the specific guidance in how to implement the standard, and all of the references are listed and they're rated based on the strength of the body of evidence. Okay, and we have some situations where we don't have much evidence or it's just really unclear, and sometimes we make committee consensus statements as well. And I do have a couple of examples of those throughout the standards or throughout this presentation. So in 2024, we actually added 3 new standards. The first one is entitled Drug Diversion and Infusion Therapy. You know, why did we select this particular standard? Because drugs that have high rates of diversion are readily available in many settings, not just acute care, but home care, outpatient, skilled nursing facilities. And there are many resources available for dealing with drug diversion, and we aggregated those references from the perspective of infusion therapy. We didn't deal with all the citations relative to, say, oral medications. But we know, I think we all recognize there's a rising incidence of diversion of controlled substances. Certainly influences included the pandemic, shift to outpatients, and often truly a culture of silence regarding substance abuse. So I'm not spending a lot of time on this standard, but it does speak to the importance of a healthy work environment and clear expectations regarding that chain of custody, administration, and waste practices when using drugs such as opiates, and having processes in place for patient medications that might be brought in from outside the facility, infusion devices, meds, and supportive equipment that support safe practice and impair that ability to divert the substance, a culture of opioid stewardship, et cetera, and looking at some of the system vulnerabilities within the organization. The second new standard is entitled vasopressor administration, so a very clinical practice oriented standard. We selected this as a new standard because there is a growing amount of research that's specific to peripheral administration of vasopressor drugs such as dopamine, epinephrine, norepinephrine, just a few examples there, and to ensure timely delivery of emergent medication and to reduce central line utilization rates. Those are some of the focuses of the research. We have seen a practice shift that's resulted in a rapidly increasing use of peripheral catheters for continuous vesicant therapy. And literally all of our vasopressors are vesicant drugs. They are drugs that can cause tissue damage if they infiltrate, go beyond the vascular pathway and get into the tissue. So some of the concepts that are addressed related to vasopressors, certainly we look at VAD planning. That's a really important standard in the 2024 and past standards as well. It's just entitled Vascular Access Device Planning, and I consider that a really fundamental, important standard to examine. So we look at short peripheral catheters, midline catheters, and CVADs, central vascular access devices, more commonly called central lines. Certainly with vasopressors, central lines are the preferred route, but therapy could be delayed if that functioning central line is not in place. So if the peripheral catheter is required, the short peripheral is preferred because it's easier to assess for any signs of complications such as phlebitis or extravasation. We do not recommend, we say do not use the midline or a long peripheral catheter for vasopressor delivery because there is a lack of evidence. We do have high occlusion rates and there is a risk of increased injury. And then some basic things in terms of VAD planning is avoid areas of flexion, and a blood return is a must with ongoing patency assessment. Now, in terms of how often should we check for that blood return, we want to validate patency by a blood return regularly. But in situations with increased line, luminal volume, and vasopressor administration, aspirating for a blood return might be contraindicated. When there's any kind of interruption of that infusion or an inadvertent bolus could cause some type of decline in the patient's condition. So, and this is where we did make a committee consensus recommendation. So in these situations, a blood return could be evaluated when the infusion is stopped or paused for other reasons, such as a bag or a tubing change, and increase the frequency of assessment of the insertion site and clinical response to the medication when we aren't doing that routine blood aspiration check for patency. So this just summarizes some of the information in this new vasopressor standard. It speaks to insertion, the training of the clinician, use of vascular visualization technology. We talked about short peripheral catheter preferred if you can't get a central line in. We talked about blood return, the maintenance piece, also kind of a repetition of some of the previous slide, but assessing patency, and try to limit to one pressor per each peripheral IV at the lowest concentration and careful monitoring. Now, we do recommend to limit continuous vasopressor peripheral administration to 24 hours or less due to lack of evidence to support longer duration. And of course, with that longer duration, we have increased risk. Should there be a loss of blood return or leakage, we want to transition promptly. We need to be able to recognize and treat any potential extravasations, notify providers, etc. And of course, proactively look at, what is the more definitive vascular access device, central line, obviously, if that patient continues to require vasopressor administration. Now, the third standard is home infusion therapy. I work in home infusion. I was a former critical care nurse who went into home care and home infusion many years ago. So there is a growing research base and certainly a big growth in home infusion therapy over the years. So we have this new standard. I'm not going to read all of the words on this slide, but we talk about the importance, and these are the standards, not referenced, but the importance of appropriate patient selection and in collaboration with the patient caregiver and the team. And even if you as an attendee, and we didn't ask this in a polling question, but if you work in acute care, for example, and not home health, you still often have a role in transitioning patients from acute care to the home setting. We need to recognize risks of complications, appropriateness of that vascular access device, patient and clinician safety need to be evaluated and considered by the home care organization, and that we provide adequate and comprehensive programs to address education and competency, have policies and procedures in place, etc. So general considerations for home infusions, we are seeing just a growth in the number of anti-neoplastic and biologic therapies. And in some cases, we can administer these at home. In some cases, we cannot. There has to be a careful consideration for safety. For example, some of these drugs may be hazardous, and as well as adverse reactions. For example, that risk for anaphylaxis. Is it safe to administer that at home based on that situation? And transitioning patients to the home care setting. Some of the things that we want to think about: is that patient clinically stable? Are there any potential environmental issues or hazards? Sometimes we don't know that as we transition from acute care to home care, but we may identify that once we get to that patient's home. Having emergency medications in place is important for patients who do have an ongoing risk of a reaction, or perhaps we're doing initial dosing in the home. And of course, the ongoing monitoring. What kinds of infusions can be home administered? Antimicrobials, biggest category of home infusion therapy. Parenteral nutrition, probably the most complex home infusion therapy to manage, particularly in patients who have long-term or lifelong needs for parenteral nutrition. Hydration solutions to treat mild to moderate dehydration. We can give some anti-neoplastic medications, chemotherapy in the home. Cardiac drugs, we do care for patients who may require an inotropic infusion, such as dobutamine, milrinone, or even lower dose dopamine for patients who are palliative end-stage heart failure to keep them out of the hospital setting, or patients who are being transitioned to a transplant or some type of mechanical cardiac intervention. So that is a specialty population as well. Analgesics for those patients with chronic pain. I mentioned the biologic drugs before, and there are others as well. The INS practice recommendations, and again, I'm not going to spend a lot of time on this slide, but the practice recommendations are all referenced and speak to all of the issues on this slide, some of which I've already addressed. The patient caregiver preference is an important one, though. Patients need to be motivated, able, and willing to participate in their care at home. So some patients might not be a good candidate, particularly if they live alone and they just are not safe to live with that vascular access device and participate in infusion-related procedures. For those of you that don't work in home care, in most cases, we do teach patients to independently manage their infusions. Most patients on IV antibiotics at home will learn to do those antimicrobial or antibiotic drugs independently, parenteral nutrition as well. Even with our cardiac drugs, they need to have a good understanding and be able to participate, because as home care nurses, we can't be there immediately should there be any problems. So they need to be able to problem solve. Use of telehealth. I think this is a research priority for us in home care. My organization is across the country. We have multiple organizations, and we do have a strong telehealth program, but we haven't implemented it so much in an organized fashion in the home infusion area. But certainly it is a tool that we can use to reinforce patient education, to monitor patients from afar, particularly those that live in very distant or isolated areas. Okay, reimbursement is always an issue in home care, and all of that has to be evaluated before a patient goes home. I wanted to highlight a little bit of the research here on transitioning the patient or the person who injects drugs to home care. This is a growing issue in acute care as well as home care. And sometimes there's a very much a knee-jerk reaction. We cannot take that patient at home out of fear that they will abuse their PIC, for example. But some patients can be safely transitioned to home care for home IV antibiotics. This has been studied in a number of research studies. And some of the positive things, if these are in place, we can expect relatively good outcomes. If they do have a safe home, caregiver support, they've been counseled about the risks, about living with that PIC, for example, they have safe housing, they're agreeable to the plan for home care and that close follow-up, and that there's good care coordination within the acute care setting between infectious disease, case management, and any specialists involved. One of the studies have shown that the misuse of the vascular access device is low despite perceptions. There are tamper-evident products available. They would not necessarily prevent the person from accessing their line, but they can't put it back together once they take it off. So, but generally the misuse of vascular access devices is low. But one of the factors that was associated with adverse outcomes was that lack of family involvement in discharge planning. So I wanted to highlight that just because we do see this. And it, given a lot of the drug issues across our country, we have to look at each situation in a very careful way and evaluate. So now I'm going to go into some additional selected standards. Okay, the increasing prevalence of midline catheters. Again, I'm not sure where all of you are from, but we definitely across acute care, there has been a real increase in the use of midline catheters. To a large degree, there has been, one of the factors has been the reluctance to put a central line in patients because of the concern about CLABSI or a central line associated bloodstream infection, and the fact that CLABSIs are publicly reported for acute care organizations. So it's led to this idea that let's put midline catheters in because they're not a central line, they're not monitored in terms of infection, or reported rather. We certainly would monitor them, hopefully. That's going to change over the next few years as bloodstream infections are going to be, at least it's proposed at this point by CMS, they will be categorized in a broader way, not just relative to central lines. But the standard 25 VAD planning, which I mentioned earlier, is a really important standard, speaks to the fact that we want to assess the compatibility of the infusates and plan duration of infusion therapy for appropriateness of peripheral catheters. And remember, a midline is a peripheral catheter. So for a midline, the general guidance is, if that patient requires infusions of a peripherally compatible medication or infusate for 5 to 14 days, a midline may be appropriate, but they're not recommended for continuous infusion of vesicant therapy, parenteral nutrition, or other infusates with extremes of pH or osmolarity. Now, we do often give intermittent infusions of drugs that may be irritants or vesicants. And in that case, we do have to really monitor carefully. We want to increase that site catheter site surveillance, not only the exit site where the catheter comes out, but the extremity, the tips of these midline catheters are resting in the upper arm. And there is a risk for phlebitis or extravasation. I call out on this slide vancomycin because vancomycin is a vesicant drug. It is associated with an increased risk for damage to the endothelium. And just as a remember point, each vein is lined with a single layer of endothelial cells that is at risk to damage, okay? In an animal study that was published in 2020, vancomycin infusion via midline catheters did result in vascular injury and premature catheter failure. So again, recognizing where that catheter tip lies, because it's in a deeper vein, it takes a longer time to see signs on that skin surface. Edema, changes in skin color, temperature, they're relatively easy to identify with a superficial short peripheral catheter, but not necessarily with a midline. And the escape of any infusing fluid has that potential to cause extensive tissue exposure before signs are visible on the skin. So again, just the importance of monitoring carefully for signs of such complications when administering any kind of vesicant drug via a midline catheter. So more research will follow in this particular area. Okay, now I'm going to talk about pain management, okay? This particular standard really grew in terms of the references. In 2021, there were 35 and there were 94 in 2024. There's just this growing body of literature that supports pain management with needle-related procedures across all age groups. Just some considerations here for the impact of a lack of pain management strategies among neonates and children. Preterm infants have sensitive developing nervous systems that are affected by pain. Repeated needle procedures in children increases the risk of development of long-term consequences such as procedural anxiety, hospital avoidance, needle fear. And I have seen that with some of our chronic patients in home health who have been getting infusions since they were relatively young. We know that any type of distraction technique does reduce anxiety and perception of pain in children. And there are a lot of references supporting this. Notably, at adolescence, as kids get older, then we don't think it might hurt anymore. So we treat them like an adult. So we're not going to worry about it. But that is not the right thing. Okay, where did my slide advancer go? There, okay. Okay, all right. Some of the barriers of pain management are listed here. Certainly, we often underestimate pain. We focus on technical tasks, time, lack of orders, workload, etc. We did a study, we never published this. Shelley DeVries, Tricia Clydon, myself, and Mary Hagel, we were all members of the 2021 standards, and we did a global study, basically a survey study. And it was really an interesting, looking at pain management. Our goal was really to take a look at, how do people implement the INS standards? And when we looked at adults, almost 56% of nurses almost never use any kind of pain management with adults, okay? And then if we look at, next slide, please go. Okay, sorry. Look at pediatric patients, 52, over half of nurses do use pain management the majority of the time. So we still have work to do here. Okay, so again, in the interest of time and a fair amount of slides here, I don't want to spend a lot of time on this, but we have a lot of non-pharmacologic interventions that can be used with adults, heat packs, cold, distraction, those behavioral interventions, and pharmacologic interventions as well. Injectables such as intradermal lidocaine, vapocoolant sprays has become quite popular, and actually that has a level 1 of research evidence, which is our highest level. So there's been a significant amount of study of vapor-coolant sprays. We had a nice presentation at our recent INS standards meeting in Kansas City by a nurse doing a quality improvement study within her organization. Their vascular access team was not using any type of pain management strategy at all with their line insertions, and they implemented vapor coolant spray. So with some good quality results. So we have options. For neonates, and this is actually a photograph of my little grandchild 2 years ago. He was premature in the NICU for about 40 some days, and I felt like the NICU really did follow good pain management strategies. There are so many needle pokes in an infant like this. So we have mostly non-pharmacologic interventions here that are safe, effective, and easily applied rather. Sucrose, glucose, pacifiers, breastfeeding, all of these things that are listed here. Facilitated tucking, oral sucrose, and that kangaroo care, skin-to-skin care, did decrease behavioral and physiologic pain response alone and in combination with other interventions as well. So very important in these defenseless infants. For children, I mentioned before, any type of distraction technique, peekaboo, blowing bubbles with toddlers, and all of those other examples as well. In terms of pharmacologic interventions with children, again, many potential options, and it certainly will depend on the resources available within the organization. So a lot of information here. The topical lidocaine prilocaine cream, which I think most of us are quite familiar with, was actually more effective than a subcutaneous needleless lidocaine injector. However, the needleless lidocaine should be considered when starting. The peripheral catheter can't be delayed. And that is one of the problems with the topical cream, is that we have to wait 45 minutes to an hour for it actually to result in an anesthetic in that area for the IV insertion. As with adults, the vapor coolant spray was associated with a significant reduction in pain. Now I'm going to switch over to needleless connectors, just highlighting some changes. These complicated little devices that we put on the end of a line. If we are using them for intermittent infusions, we have options for active versus passive disinfection. And active means we are going to use an alcohol wipe or perhaps a CHG wipe that's appropriate for that use, and we're going to scrub it for a period of time based on your organizational protocols and manufacturer's recommendations. And then you allow it to dry. They dry relatively quickly. And then the passive disinfection would be the disinfection caps. There are a number of different brands of disinfection caps, basically a plastic cap with some foam inside that is saturated typically with 70% alcohol, and it lure locks onto the end of that needleless connector, providing continuous disinfection. Now, comparing to active disinfection, the passive disinfection has been associated with increased clinician compliance, basically because you have that continuous dwell nature of the device sitting on that line. Other studies show no difference between passive decontamination with caps versus active with swabbing. We certainly need more high quality research in this area, and I know it is a topic of research via several researchers. So right now, I mean, both are considered acceptable. In terms of changing that needleless connector, I put this in just because there are often questions even once the standards come out, like how often do we change these? And basically it lists, if it's removed for any reason, prior to drawing a sample for blood culture from a central line, that's important because if you draw a blood culture through that existing needleless connector, you increase your risk of false positive culture results. So that's very important. And then we just say per local policies, procedures, or practice guidelines. If there's manufacturer's recommendations, we would follow those. And when clinically indicate if there are any problems with the device. If we're using it within a continuous infusion system, it would be changed when the administration set is changed. Okay. So variation in research and the context, does reiterate the need for sound product knowledge and regular device assessment to ascertain optimal function and integrity of these devices. They appear very simple, but yet they are more complex than we recognize. In terms of our committee consensus statement, we did change our recommendation here to disinfect the needleless connector before re-entry on contamination or suspicious contamination of a key part. For example, okay, we are getting ready to do a saline flush through that needleless connector. We scrub it with alcohol, and maybe we inadvertently touch it. We need to re-scrub it. Or maybe we've got that cap off of the tip of the flush syringe. We pushed the excess saline out, but we inadvertently touched that tip. So we want to re-disinfect it. The studies that focus on the disinfection practices before the initial entry into the needleless connector, but they don't address the disinfection before each subsequent re-entry. Typically, we've said hours scrub before each entry. I still believe that is the best practice, and certainly in the area of home infusion, we typically teach patients to do that, and we set that all up for them, understanding scrub before every access of that needleless connector, before the saline flush, before the drug administration, before the next saline flush, etc. Okay, standard 37 is entitled Site Protection and Joint Stabilization. This was a merging of two separate standards. These were separate before, and we redefined what site protection is. Okay, and these are strategies that are used in addition to vascular access device insertion site securement. I didn't go over the securement standard here, but when we're talking about the securement, we're talking about at the actual site, whether we are using skin glue, tissue adhesive, which is a growing practice. Maybe we're using an adhesive type of device that's on the skin that has a way to attach to the PIC or the midline. We have integrated dressings for securement. So that is a separate type of securement. Now we're talking about protecting it beyond that. That could include interventions or products that are used to reduce the risk of bad dislodgement due to pulling or tugging of the administration set. There is a new category of devices called the force activated devices. And when this is attached, as part of your continuous infusion with a peripheral or a central line continuous infusion, if say the patient got out of bed and pulled, it would actually separate so the line would not be inadvertently dislodged. So that is a new category of product. We have other products that might be used to protect or disguise the vascular access device from manipulation. For example, pediatric patients, and I have a picture of that coming up. And it's also strategies to prevent exposure of the bad site to water or other contaminants. This is particularly important in our patients receiving home infusions. And they have a PIC or a midline or some type of catheter in place. We need to teach them how to protect that site. There are a number of commercial products available that can be used. Some patients may use some type of plastic wrap as well. Joint stabilization would be used to support and stabilize the joint if we have that catheter in an area of flexion, okay? And then and we want to avoid that for the most part. We want to avoid areas of flexion just because we know we increase our risk for infiltration, phlebitis, for example. Physical restraints would be a manually applied method that immobilizes or reduces the ability of a patient to move themselves, arms, legs, body. So some of the standard, the practice recommendations within the standard do speak to the fact that inadvertent bad dislodgement is a clinically important problem. We do have lines that are pulled out, and we don't want that to happen. And we know that patients who have cognitive issues or children are at increased risk. On this slide, I do have an example, and that actually is my granddaughter too. She was in the hospital for a cellulitis type of infection, and she had IVs for a couple of days, and they used a a protective device to keep her from, touching or manipulating the catheter in her arm. I talked about it. The small studies have shown efficacy for devices, the force activated. The use of mittens or mitts may be used as a site protection intervention as an alternative to physical restraints. They're not considered a physical restraint if they're applied without any other restraint when the patient can easily remove it. And we have singular tubular sleeves that can be easily removed for additional site protection. This actually is a common intervention that we do in home care. That patient has a PIC or a midline in their arm, and we'll use a piece of surgical mesh gauze, and that can slide up their arm and kind of protect the area, and you can tuck up the extension sets of the midline or PIC, so it's not interfering with their ADLs. We talked about tamper evident devices as well. Okay, so a lot of new information, a lot of new references in that standard. We want to avoid those physical restraints just because they impact dignity and they can increase anxiety and agitation. We don't have data that really substantiates that restraints prevent device removal, and yet they are quite commonly used. Certainly, the use of temporary physical restraints can be considered in situations such as a central line insertion to ensure the ability of the clinician to place that line aseptically. And I think for those of us who are parents, we may have even done this, but you don't want to um, use physical restraints or hold down your child for a painful procedure. To try more of a hugging approach, and certainly you could look at our other pain management strategies and distraction strategies rather than holding this child down, because that can cause a lot more anxiety and build fear for the next time. So enough on that standard, and I'll move on to phlebitis. And of course, phlebitis is a very common complication of IV therapy, and it can occur obviously mostly with peripheral catheters, but also with midline catheters and sometimes with PICCs as well. And it's based on the patient population, the type of therapy, risk factors for phlebitis, and we need to really instruct that patient to report pain or tenderness. This is a really important component of ongoing care in any setting. The patients understand, in their words, using their words, how to teach them what to report, what to look for. So our general guideline for peripheral catheters, the most common type of device certainly across all of our settings, is to remove and reinsert peripheral catheters based upon clinical indication. Many organizations have gone to clinically indicated removal. We've actually supported this based on the research with the INS standards since 2016, I believe was the first time we cited the randomized controlled trials that supported clinically indicated versus taking out that catheter at 72 hours or 96 hours. It looks perfectly well, good. There's no problems in terms of assessment. The patient has no discomfort, but we would take it out and put it elsewhere just based on time. So the studies continue to show that there's no clear difference in the rate of phlebitis between clinically indicated or routine replacement of that peripheral catheter, and it's based upon very high level research. It is important to recognize pain. That is an early indicator of phlebitis. So if a patient is having pain with infusion, we need to look at that very carefully. Many of our organizations use a standardized phlebitis scale or definition, and if we do, we should use it consistently within that organization. However, it's very interesting that there are limitations of the existing tools. In studies that have looked at application of different tools in the same situation, we don't necessarily have reliable results. We definitely need further study in this area. So that was a challenge in looking at this particular standard, is we really don't have this well-validated, reliable tool for phlebitis. We did include in the INS standards the INS phlebitis scale. I would say it's widely used by many organizations, but we certainly need more research in the use, the reliability and validity of that tool. But it's often built into the electronic health record. I've seen that numerous times. Now, what causes phlebitis? We're really looking at three separate areas, and I think this is really important for every nurse to understand. We have chemical phlebitis, and that means that we have that endothelial inflammation or injury due to irritating infusates. And we know certain antibiotics, we talked about vancomycin and extravasation, but it causes phlebitis as well. Amiodarone causes significant phlebitis. So there are a number of medications that are listed in the standard. I didn't pull them out in this slide here. Inadequate hemodilution. It's a very concentrated drug. Excessive infusion rate. If we're giving multiple medications through a single peripheral catheter, for example, particulate matter can cause problems, and skin antiseptic solution that's not fully dried, which really comes back to the importance of um, making sure that antiseptic solution is fully dry before you put in any type of vascular access device. And then we have those mechanical effects on endothelial cells. And I see a typo here, but high catheter to vein ratio. Large catheters, small veins, direct irritation of the endothelium. Insertion in the area of flexion, the movement is going to cause irritation. The angle of insertion and position can affect it. The Teflon catheters are associated with more irritation of the endothelium than other types of catheters. And there's a lot of growing research in terms of the composition of our vascular access devices as well. Inadequate securement, the catheter is not secured well and it's moving in and out at the site. Infectious bacterial contamination, inadequate skin antisepsis, contamination of the catheter during insertion. So it's really important to recognize the importance of aseptic, non-touch technique during all infusion-related procedures, from insertion of that line to every access of that line and to the ongoing site management. So how do we reduce the risk of phlebitis? Certainly beginning with the VAD planning. Again, we kind of call back to that important standard frequently in the bigger context of additional standards. Choosing that smallest catheter for the intended therapy. Consider larger veins, secure the catheter well, avoid areas of flexion, avoid lower limb insertion. The exception would be neonates and infants that are prior to the age of walking, and stabilize that joint as needed, which I spoke to earlier. Evaluate or mitigate drug-related factors, including dilution. Certainly consulting with a pharmacist may be helpful. Not all drugs can be diluted to be non-irritating, but we can consult with the pharmacist. Considering insertion and maintenance bundle to reduce complications, including phlebitis. We don't have a well-developed insertion and maintenance bundle, but there are some available. And replace a catheter inserted emergently under suboptimal aseptic technique when that patient is stabilized, and certainly within 48 hours. I have seen some very significant cases where that patient comes in from paramedics. They don't necessarily, the patient is in, it's life or death, and they're not taking the time to do all of the skin antisepsis and all of that preparation because we just need to get a line in to save that patient. So if that is the situation, that patient had that line placed, in an emergency type of situation, we want to replace that. We want to remove and replace it because of the high risk for a bloodstream infection. Move any catheters inserted in a lower extremity to an upper extremity in adults, and move to a new proximal site, so above previous problems with that area, above that previous area of phlebitis, or to the opposite side for pediatric patients. In terms of interventions for phlebitis, we remove the catheter. That is critical. Now, there are situations, this is not very common, but you can get a transient mechanical phlebitis after insertion of a midline or a PICC. Basically, as that catheter is threaded through the vein to its intended destination point, it can cause some irritation of that endothelium. So in that case, we can monitor, and this would happen pretty much within a day after the insertion. Ensure the catheter is secured so there's no movement. We can look at heat, elevation, and monitor for up to 24 hours. But if those signs and symptoms persist, it would indicate removal of the catheter. So this is another example of a committee consensus statement or recommendation. In terms of interventions for comfort, there's not a lot of research here, but warm might be helpful. Cold might be more comfortable for patients. Limb elevation, significant phlebitis, analgesics might be needed, or other pharmacologic agents such as an anti-inflammatory. And I think the fourth point here is really important. When a patient suffers an episode of phlebitis, we need to really reevaluate that need for what is their ongoing vascular access, especially when chemical phlebitis is suspected. Does it make sense to put another IV in another place when we're administering multiple medications through that peripheral catheter? And maybe that patient would benefit more from an alternative vascular access device such as a PICC if they're going to continue to need these irritating drugs over a period of time. In terms of infectious phlebitis, if there is any suspicion of infection, or if there's purulence present at the site, that catheter needs to be removed. The culture needs to be taken of the exudate and the catheter tip. Document those findings and monitor for signs of systemic infection. In cases like this, and I have been involved in evaluating these types of cases, oftentimes what they need to do is actually surgically remove that vein due to the purulent drainage within it. So it's a surgical remover. So that is a very serious complication of a peripheral IV. And honestly, it's called infectious phlebitis, but it is truly infection. Okay, this is one of my last slides. I think it's a second to the last slide, but I want to just highlight standard 55, subcutaneous infusion and access devices. If we look at this, subcutaneous infusion is a growing practice and is considered an alternative to IV access as part of a vessel health and preservation strategy. Okay, that is in the actual standard. So what we're seeing is the possibility of subcutaneous infusion of medications based on a systematic review of the literature. Subcutaneous administration of opioids is actually quite common, especially in hospice and palliative situations. Hydromorphone, morphine, ketamine can be administered subcutaneously as an alternative to IV. So it is a simpler method, not atypical in a hospice type of situation. So you don't have to put the patient through insertion of a vascular access device, whether that be a peripheral or a PICC. There are some antimicrobials, ceftriaxone and ertapenem, that have been found to be safe to be administered subcutaneously. I did a live presentation at an INS chapter last week, and surprisingly, I had a lot of response in a live audience there, and they were definitely seeing increased subcutaneous administration. This was particularly home infusion. Immunoglobulins can be given IV or subcutaneously. That is a very common practice in Europe, but certainly not uncommon in the United States as well. Obviously very much a specialty. Drugs such as deferoxamine has been given sub-Q for a long period of time. Subcutaneous or IV administration of diuretics in the management of heart failure has been associated with symptom relief, and there is a new subcutaneous formulation of furosemide that is commercially available. It's what they call an on-body subcutaneous device, and you pop it on. It has a small needle, catheter there, and it infuses the furosemide over a few hours. And there is growing interest and availability of on-body subcutaneous infusion systems. So look to see more in this area. We can also administer fluids subcutaneously. This is called hypodermal crisis. And I always feel like I need to do a little bit of sell job to our clinicians on that, but particularly in home health or in skilled nursing facilities, you have a patient with mild to moderate dehydration who could benefit from a liter or two of saline. We can administer that subcutaneously. It's very simple. You run it in generally gravity, and it dissipates in the subcutaneous tissue. It's very painless, and you can't run it very rapidly. Basically, through a single site, you can do about 60, 70 mLs per hour. But it is a cost-effective and clinically effective way to manage dehydration, potentially without hospitalization for patients who might be recovering from some type of illness. Okay. There we go. Okay, so this actually is my final slide before we get to the Q&A, and I think I'm doing fairly well with questions. We have some time for questions, but just to summarize here, you can kind of read it along. But my presidential theme was advancing the science of infusion therapy when I served as president, and certainly I'm honored that I've played a role in continuing this theme. So this is my closure. Again, I'm not going to read all the words here. You can take a look, but it was my closure after 20 years of being involved with the standards, and it is published at the end of the standards. So I am going to thank you all for your attention today. I know I covered a lot of information here, but I'm going to turn it over to Mary Alexander so we can do some Q&A.
Thank you, Lisa, for that great presentation. A lot of information to cover in a short period of time. I'd like to inform our viewers, though, how to obtain their CEs for this session. So for continuing education for nurses and respiratory therapists, this activity has been approved for 1 contact hour. You can obtain those continuing education credits by logging on to www.saxtesting.com/P. You will need to register on the test site, complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. This activity is supported by an education grant from Dale Medical Products, Inc. An archive on-demand version will be available on www.perspectivesinnursing.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for CE. So we do have quite a few questions, Lisa. And to our viewers, again, thank you for being here. Lisa will try to answer as many as she can. But the first one is, and can you comment on this? She states, one concern, midlines are considered a peripheral device. Leadership is at times supporting bedside nursing staff learning how to place midlines at the bedside. This is one of many potential problematic situations when the system does not employ or support the development of an established vascular access service or team. Can you comment on that?
Yeah, I mean, very good point. I mean, the insertion of a midline catheter does require ultrasound. It requires understanding of tip placement. It requires understanding of evaluating the best vein for insertion. One of the guidelines is that you do not want that catheter to take up more than 45% of the vein that the catheter is inserted, which allows for good hemodilution. It allows for good blood flow and reducing the risk of complications. So absolutely, anyone inserting a midline catheter needs to be highly skilled and competency needs to be assessed.
Yep, I totally agree.
Yeah.
Kelly is asking, wouldn't vapor coolant sprays interfere with vasodilation and aiding in insertion of a peripheral IV?
Yeah, it's a very good question, but no, it doesn't. I mean, that was always my concern as well. okay, that this is going to, constrict the veins. We won't be able to get in, but it does not do that. I have used it on occasion. I do still see some patients and place peripheral IVs. And it is quite cold, sometimes uncomfortable for some patients, but no, it does not cause that vasoconstriction. And that's why it's really grown in popularity. It's relatively easy to do.
Great. Catherine is asking, embedded within the standards, is there a list of medications that are of concern in various categories to watch the site when infusing, such as Vanco and pressors, etc.? I'd like to post it to remind staff.
Yeah. Okay, so the other thing that is coming out, another committee that I led was our Vesicant Task Force. We actually presented on that in last November, but the paper is actually coming out in the October issue of the Journal of Infusion Nursing. We actually updated all of our Vesicant list. It's a very large article looking at all the research that we used in terms of identifying our high risk and moderate risk vesicants, but that will be available in September, and I know people are just waiting for that. So we have expanded that list that includes all of the vesicant drugs based on our review of the literature.
Great. Let's see. I appreciate the updates. Sorry. What is your recommendation for infusing incompatible meds? We teach to either disconnect infusion and use a normal saline flush bag to infuse an IV piggyback, or to clamp IV line, assess patency, flush the line at the lowest port with 10 mils of normal saline, attach flush bag of normal saline, and attach IV piggyback.
I mean, all of those things are fine. I mean, it is complex when you're administering a multitude of drugs that are incompatible and can potentially precipitate when together. So, I mean, all the things that you're doing are absolutely fine. You need that flushing in between, so there's no, meeting of those two drugs in the line.
Let's see, we've got a bunch here. I'm trying. From Anne Marie, is your recommendation for assessing patency the same? Is your recommendation for assessing patency the same? Infuse normal saline, aspirate for blood return, continue flush.
Yeah, basically your SASH procedure.
The other, sorry, I have one more. What is your recommendation for changing the needleless connectors with TPN?
Yeah, that is a very unanswered question. Okay. And we really looked, for an answer there. I mean, technically, you would change it with your tubing change. We change the tubing every 24 hours with any kind of parenteral nutrition. I feel like it's just an unanswered question. So you have to look at your organizational guideline. I'm not convinced that changing it every single time makes sense, to be perfectly honest. But we need to get some data to answer that question. So right now, people are just following what their local policies are. Yeah, great question without a clear answer.
And this will be the last question because we're a little bit over time. And this is from Gina. Site rotation of a butterfly in a home care setting where the medication is the only thing being administered. Changing it at each administration seems unnecessary. Intermittent infusion suggests with each administration.
I'm not quite understanding. Okay,
I'm
when you
wondering
say
if that's for a sub-Q. Yeah, I think it's for a sub-Q administration, Lisa, is what I was thinking it is.
okay. You don't need to change the site. I mean, with a lot of the sub-Q administration, we're actually using small catheters. It goes in with the needle and the needle comes out just like a peripheral IV catheter, and you can leave that in place, okay? There wouldn't be a need to automatically remove that. So without a little bit more context, I guess that's the best answer that I can give.
Yeah. Okay. Well, our time is up. We could go on for a long time answering questions, but I'm just now going to turn it over to Tracy. And again, thank you, Lisa, for this great webinar.
Thanks, Mary. Thanks everybody
Thanks.
for attending.
Thank you, Mary, and certainly thank you, Lisa. We'd also like to thank everyone for attending this webinar. Immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. In 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits. www.saxtesting.com/P. And with that, this concludes today's session. Thanks so much and have a great rest of your day.
Thank you.
Thank you.